I'm a group leader and professor of transplantation at the University of Cambridge with a particular interest in monitoring the immune system and the immune response to regenerative cellular therapies, to transplantation, and to cancer. By way of disclosure, I'm also a chief medical officer at Oxford Immune Algorithmics. Now, we know that the immune system is a complex biological defense system, and its evolutionary has risen to protect us against protect the host against infections. It is active in all organs and tissues and consists of a broad range of specialized cells, proteins, and chemicals that interplay in a very complex manner. Now, we've been aware of the importance of the immune system for decades or even centuries. However, what I'd like to put to you is that our strategy of monitoring the immune system at the population level is really crude, and there's much opportunity for delivering better care for our patients. The white blood cells, of course, have a central role in the function of the immune system, and they consist of lymphocytes, macrophages, neutrophils, eosinophils, and so on. There is increasing evidence that really the function of the immune system and perturbations in the immune system are critical to disease, not just in infections and autoimmune diseases where we've been familiar with, but really across all conditions. What I'd like to do is to give just a little summary of evidence of some of these other emerging areas where the immune system is important, and then really hopefully make the case that we should be better at monitoring the immune system, and remote monitoring specifically is going to be important. Now, for example, we know that the immune system is important in neurodegeneration. There is increasing evidence that immune signaling is implicated in the pathogenesis and the response to neurodegenerative disorders such as Alzheimer's and Parkinson's disease. And this concept of neuroinflammation chronically is now becoming increasingly recognized, even for conditions that are unnecessarily associated with the immune system. We know that there is crosstalk between the inflammatory pathways and circuits within the brain, and there is now evidence that even mental conditions such as depression and anxiety have a critical immune component. Now, these influences of the immune system are being increasingly recognized, and there is an opportunity for developing new therapeutic modalities, for example, for the treatment of depression. An emerging area is the microbiome. So the gut microbiome, bacteria are now increasingly recognized to be important, not just in diseases of the gastrointestinal tract, such as inflammatory bowel disease or irritable bowel syndrome, but actually that the immune system response to these microbiome is important in conditions such as asthma or non-alcoholic fatty liver disease or metabolic disorders. In other words, the immune system seems to connect the response to this microbiome with conditions that have not historically been thought to be immune mediated. Even on a day-to-day basis, and for people who aren't really diagnosed with any conditions, there's evidence that, for example, the sleep-wake cycle affects the immune system, and this results in a feedback loop that can ultimately affect how the body responds to both internal and external challenges, for example, in the context of sleep disorders or mental or physical performance. We've known for some time that, of course, there is a difference in susceptibility of females and males to a number of conditions, some of these that are listed on this slide. And again, there is recognition that some of these differences at least may be explainable through the differences in the immune system between male and females, probably underlined by the effect of the hormonal system, the sex hormones on the immune system. And then, of course, the implications for aging, pregnancy, mental performance, and physical performance is being increasingly recognized. And the question is, well, how do we decipher this complex interaction between normal physiology, pathology, and the immune system? Now, my proposition here is that actually the first point or the first step in doing this is to be able to monitor our immune system as thoroughly as we can for as many people as we are able to do. So the immune system is critical for health and disease, and changes in the immune system are biologically important. Now, how do we monitor the immune system? Of course, you can have very complex monitoring, looking at all sorts of subset of cells, cytokines, and so on. But that's typically really only done in the context of very advanced studies performed on very small number of patients. What happens to normal people, right? How is the immune system monitored in the typical person who either is well or actually starts to feel unwell? The most common test performed worldwide is actually a full blood count, and this enumerates the number of cells in the blood and the subtypes. And here is a typical table of what normal values would look like. Now, this test is very commonly performed more than 4 billion times per year, so it's a real opportunity for gathering data. But how do we analyze this? What I'd like to do is to draw your attention to, for example, the white cell count, the total number of white blood cells. And what you can see is that for a male, the normal values or the reference values are between 4 and 11, and for a female also 4 to 11. When we look at neutrophils or lymphocytes that are subset of white blood cells, these numbers are between 2 and 7.5. It's strikingly obvious that actually this is a vast range. What the implication of this table is, and how we teach medicine, how we practice medicine, is that actually when somebody's neutrophil goes from 2 to 7.5, or the lymphocyte count goes from 1 to 4.5, that this difference doesn't matter. Now, to me, this seems like an astonishing basis for practicing medicine. What we are saying is that actually, if my lymphocyte count goes up 450%, that actually this is information that we can ignore, and that this information has no value because it is within the population reference range. So what we're doing here is treating the data coming from the most commonly performed medical tests worldwide in a binary manner. And we are actually categorizing as patients as being normal or abnormal based on population norms, which are very wide. Well, does it matter? Does it matter if our white cell count goes from 4 to 6 to 8? Should my physician and should my doctor be monitoring this? And could we ultimately generate insights from this? Now, this is a very important study, in my opinion, that was done, published at the end of 2017. And what the authors did in this paper is they looked at over 100,000 patients who were registered at GP surgeries, either in the UK or in New Zealand. Now, in these patients were selected so that they had no other past medical history. There was no, they had no active conditions that they were being treated for, and also they were selected so that they did not have any predisposing conditions to common disorders such as heart disease. What I'd like to draw your attention to is this pink slot here. What we have is the total white cell count of this population arranged from low to high. And the pink rectangle represents normal values. What you can see is that if your total white cell count is very high, well, you have almost 7.5 times increased likelihood of death. And actually, if your white cell count is very low, you have almost 12 times higher risk of death. But the critical point here is that even within the normal range, if your white cell count is between 5.3.5 and 6.25 versus 8.65 to 10.5, you're actually 3 times less likely to die. So in this scenario, a simple study demonstrates that if we adjust for all other risk factors we can think of, age, sex, smoking, diabetes, blood pressure, ethnicity, cholesterol, etc., actually, if we follow up people long enough, even within the normal range, something as simple as a total white cell count can impact our overall risk of mortality. Now, the argument here isn't that we should really alarm our patients when their white cell count goes from 5 to 6 to 7. But the point is that we should be gathering this data, and we should be able to correlate it with outcomes to ultimately understand it better. Now, what about the individual subsets of blood cells? So what you see here are some of the key subtypes of cells, so B cells, monocytes, natural killer cells, CD4 T cells. And what these violin plots demonstrate is that actually within the normal range, different people have different proportion of these cells in their blood. So some people's CD4 T cell count can be 22% of the total population, whereas in others can be 93%. Now, we don't understand what that means. And the reason we don't understand what that means is because we simply do not report it. We don't collect the data, we don't analyze the data, and we don't report it. But there's increasing evidence that really we should be moving away from this idea that you've got a completely heterogeneous population with very large normal ranges, but rather that there are discrete immune phenotypes that actually, if we were to understand these better, we can make better predictions. So the idea is that we should be moving away from this binary categorization of blood results from normal and abnormal, but rather be thinking about what is the baseline values for an individual person, and when they start to deviate from it, be able to assimilate it. Here is another study only a couple of years old, and what they did was they took, again, completely healthy people, and they looked at the number of CD8 T cells. These were particularly people aged between 60 and over 90. And what they noticed is that actually for some of these patients, the number of CD8 T cells increased over time, in some of them decreased, and in some didn't change much. And this was now in the absence of any known health problems. And importantly, what they came up with was this concept of an immune age. And actually, they showed that their immune age was a better predictor of death than their chronological age. So again, the proposition here is the immune health is not a binary variable. We need to understand it better, and we need to really reframe our definition of normality and move towards a personalized system. Now, how do we do that? Well, we need to be able to generate longitudinal personalized data. I've mentioned immune data, but actually this concept of personalized monitoring shouldn't be limited to the immune system. If you are monitoring liver function, for example, we need to be able to monitor it in